Hey, what's up, everybody? I don't know if you guys saw my recent post. Haley Prescott's going to be on Brandon and Brian's podcast tomorrow, who's ICU Scenarios. So if you guys have any questions, I guess you could drop them here and I'll try to write them down or DM them to me or send them or comment them. So what we're talking about is the new Surviving Sepsis guidelines. And, so the first thing is that these guidelines are probably really hard to sort of coordinate. So obviously, thank you to the authors for putting the time together, and it's just unpaid, and they don't, I'm sure they don't take money from this, and they don't, the time is all donated and that kind of thing. So the first thing is, does anyone have any specific questions on the guidelines that we could talk about? And then if there's not, then I can sort of start to go over them in some way. There's a few sort of newer recommendations. There's a couple downgraded and upgraded things from previous recs that have changed. Specifically pre-hospital antibiotics is one of the things that really caught my eye. They have only changed the language. What language are you talking about? Some of the specific language? Because there is they did, there's a bunch of new sort of newer recommendations. Things have gone up, have gone down. The sort of the first couple things is the stronger words level recommendation. Yeah. It depends on how much evidence there is for such recommendation. So that, strongly suggest, and I don't know, I don't remember the old, the 2021 guidelines, if that's changed from there. But, so the first couple of pages, sort of a bunch of the different recs, and then, you get into the graded. So they're using the grade approach. So classified recommendation, either strong or conditional. So as you're pointing out, they refer to this as weak recommendations and prior guidelines. I guess I don't know if it's more semantics or not. I don't sort of get into that too much. I think the first thing is, the interesting thing in this is sort of table 3, which is the sepsis terminology, which is definite sepsis, probable sepsis, possible sepsis, unlikely sepsis. Sepsis, as they get into in the rest of the guideline, is this very nebulous sort of diagnosis that's clinical. And the first thing about a clinical diagnosis is that you sort of have to take in all of the things, meaning your labs, your physical exam, the history, and then sort of your gestalt, which makes it the clinical diagnosis. So I think the first thing that sticks out to me certainly is this pre-hospital antibiotic recommendation. It sticks out to me because they make a recommendation for pre-hospital antibiotics, and then say that we should be screening patients pre-hospitally for sepsis, but they can't suggest anything. They sort of don't suggest how to do that, which is something that I'm going to sort of ask Brandon and Brian to ask the author tomorrow, because they go over sort of the news score, the Muse, QSOFA. So QSOFA is sort of out, for pre-hospital. We don't know how to screen the patients. We don't know what to use to screen the patients. For in the hospital, they recommend using News 2, Muse, or SIRS sort of more than QSOFA, which is fine. They say in the guidelines specifically, which I agree with, is that these are sensitive tests, meaning you'll sort of catch everyone with sepsis, which is what we want to do, but they're not specific enough. And that was sort of I think it was a post I put out before, is that the specificity of all these things is not as high as you would want. So what it's good at doing is saying, is this patient sick? What it's not great at doing is, does this patient have sepsis? Which gets back to the original point of, how do you sort of define sepsis? And if sepsis is a clinical diagnosis that's not easily defined, then how are you going to, in the pre-hospital setting, recommend antibiotics without sort of a definitive gold standard sort of definition of sepsis, or a gold standard way of identifying sepsis in the field with a high degree of specificity? So yeah, the culture thing we'll get into. So that being said, do I think, and they sort of qualify it with longer transport time, 60 minutes, etc. I do think at some point it would be good to sort of do that pre-hospitally. I don't know what that would look like. I don't know how you would do that. I don't know what agents you would use, because if you pick up an elderly person at the nursing home and they have 107-degree fever and they have Rogers, and you're this is slam dunk infection, it's definitely sepsis, it's septic shock because now they're on norepinephrine, it's definitely sepsis, that's fine. But without more diagnostics, what is it? And I guess if the patient's is hypoxic, you can sort of think this is probably a pulmonary source. I guess if they said they've had like dysuria, you can point to a urinary source. But in the hospital, at least, we see these things get sort of confounded all the time. So why that's important is it depends on your sort of antibiotic choice. So outside of like going extremely broad for everyone, it's going to be hard to parse out what antibiotics to use pre-hospitally, even if you could screen these patients effectively, identify sepsis with a high degree of specificity. Like, what antibiotics are you going to use? Are you just going to give vancomycin to everyone? That doesn't seem like a great move. Like the antibiotic stewardship, and if there are allergies and all this other kind of stuff. So I do think there's going to be sort of like a niche for pre-hospital antibiotics. I do think it's going to be eventually maybe with like better identification or rapid identification or something. I do think that's coming down the pike. I was surprised, honestly, to see it recommended. And then I think the recommendation sort of fell short in some ways because we don't know how to sort of screen the patients. We don't know how to sort of identify who is septic specifically. We can screen who is sick, and that's fine, but we can't identify who is septic. So notwithstanding, I saw this sort of talked about on other socials that there is like a larger RCT that showed that pre-hospital antibiotics didn't decrease mortality, but they didn't include that in the guideline. It's sort of in the lit review in the guideline itself. They just included, I think, a few observational meta-analyses. So, like the level of evidence in that like isn't particularly great. So, the pre-hospital antibiotics, I think, is interesting. I think we might get there at some point, but I don't know if we're there yet. I mean, I still don't know how to really identify patients in the hospital who have sepsis with any degree of accuracy. We're good at identifying who's sick with these scores, but like who has sepsis specifically, it gets harder because sepsis is a clinical diagnosis. So you need a clinician to put all the pieces together to say this patient has sepsis, which I think is difficult to do. And it's going to be difficult for pre-hospital providers to do. So getting back to the blood culture thing, when you give antibiotics, it does decrease your yield in blood cultures. A newer recommendation, at least from here, which is number 7, for adults with possible, probable, or definite sepsis or septic shock. We've recommended collecting blood cultures as soon as possible and ideally before the administration of antimicrobial therapy. So this is my issue with blood cultures. Blood cultures are exceedingly rarely positive. And if you work in the hospital, I think, depending on where you are, if you're sort of hospitalist or like floors, if you're ICU, you might see more sort of you might see more cultures that come back positive. A lion's share of the cultures are not positive. So is it good? Is it helpful to have a blanket statement that everyone should get blood cultures if we think it's sepsis? What increases the yield of blood cultures? What increases the yield of blood cultures is your pretest probability that the patient has some bacterial bloodborne infection. There was a wonderful review article that got overshadowed by coronavirus that I always give to the residents, whoever I'm with, that is this article. So, does this patient need blood cultures? A scoping review, indications for blood cultures in non-neutropenic patients. So this is a great article because what it points out is the patients who have the highest pretest probability for having bacteremia, where getting cultures would be helpful, are patients who have severe sepsis, which again is like been worked out of the verbiage, which is even more confusing. But you can imagine someone who's septic, who is like sick AF. So who has this severe sepsis or septic shock or something you would think is a bloodborne illness, infective endocarditis, endovascular infection. They have some dialysis line that is like pus is coming out of. Those patients are going to have high pretest probability for bacteremia. So getting cultures in those patients is going to be very, very high yield. What unfortunately we do is every patient that comes through the ED with sepsis, because of these guidelines, specifically how CMS has adopted them, they ding positive for a sepsis screen. And that comes with sort of like, the trifecta. It comes with fluids, antibiotics, blood cultures. Or I guess the quadfecta. I forget the term. The fourth thing is the lactic, which, we can get into later, but which they didn't really like dive into here because nothing's really changed from the 2021 guidelines. But lactic has its own issues. If you guys remember, at least in America, probably like 6 to 12 months ago, we ran out of blood culture bottles because we got so many blood cultures for patients with low yield pretest probability that your blood cultures are going to be positive. Things like non-severe sepsis, things like non-severe pneumonia, things like simple cystitis, things like isolated elevated white cell count, fever. So you probably see in your hospitals ad nauseum, someone has a fever and someone says they might be septic, and then they get blood cultures. Those are not high yield. That's not a high yield pretest probability that you're going to have bacteremia. So just like isolated fever, isolated elevated white cell count. The things that are going to increase your pretest probability for bacteremia, where getting blood cultures is going to be positive and help you determine therapy, is severe sepsis, septic shock, some vascular tree infection, some device infection. That's going to be a high pretest prob for bacteremia. That's where blood cultures are going to be really, really helpful. When you have low pretest probability that your blood cultures are going to be positive, you're going to have high false positive rate. So all the time, 1 out of 2 cultures are coag negative staph. The patient stays on vanc for some amount of time because they're going to wait for it to come back, but it's ultimately a contaminant, or we ignore it altogether. But again, the Surviving Sepsis Campaign has been so like tightly woven into CMS, which is why ASEP has sort of like refused to endorse these guidelines, because ASEP feels like they're not the most up-to-date evidence-based practice. They also think that they're sort of losing sort of the bedside applicability because of how heterogeneous this population is. So, you know, saying 30 cc's per kg for all the patients, or saying like sort of specifically the fluids and everyone should get antibiotics, and then the timing. So, you know, the other thing is like the lactic. I feel like we've beaten that to death, so I'm not going to sort of go over that. Lactic, you know, lactic is a poor test for does the patient have sepsis. Lactic is an okay test for is the patient sick. Those are 2 separate questions. But I think the problem is that it gets sort of like baked into sepsis it gets baked into does this patient have sepsis? And then someone says we should get a lactic. And that's like sort of not how it should be used. It shouldn't be used as like a sepsis screening tool. It should be used as like, is this patient really sick? And if you think the patient has sepsis, and again, that's a clinical diagnosis that a clinician should make with all the data, the physical exam, the assessment, the history, etc. If the lactic is elevated, what that should tell you is this patient's sick, we need to do something, whether that's find the infection source, give broad spectrum antibiotics, resuscitate the patient, however, you know, you see fit. Unfortunately, we still have this like 30 cc fluid bolus per kg in the guidelines, which, you know, is wrought with questions and questionable evidence. And is the fluid bolus now just becoming like this dogmatic thing from the Surviving Sepsis Campaign? I feel like it's going sort of in that direction. I feel like they've been better in these guidelines, at least sort of giving more leeway to how much fluid to give. There's actually like a really nice table on, I think it's table 4, which is on like on page 19 of the guidelines, sort of like parses out if the patient's obese, or so either underweight or overweight, so you don't sort of under resuscitate or over resuscitate. They give you sort of more specific guidelines on like what weight to use based on like ideal body weight or actual body weight. You know, I don't know, and I didn't go through like is that evidence based tested? Like, you know, we have ideal body weight for tidal volume, that's like from ARMA, but is resuscitating based on ideal body weight in like a severely obese patient? Is that like an evidence in the sense that are there trials sort of saying that, you know, that is what we should be doing in like an obese person? Or are we just saying the patient's obese, ergo we shouldn't take their actual body weight, we should use like their adjusted body weight? So that part I don't know. And honestly, they highlight in here as well that we should be sort of like tailoring our resuscitation. We should use more sort of like dynamic measures. So things like echocardiographies have sort of worked its way into the guidelines, pulse pressure variation, stroke volume variation, which all have their issues. So you have to sort of use them carefully, but at least like they're sort of, that has been sort of like upgraded in these new guidelines. Sepsis specifically is sort of, unfortunately, I think has a lot of like dogma within it. So if you go back, so it's like the historical context I think is interesting. So sepsis from its inception, you know, like 1999, Roger Bone, and I think Roger Bone was the president of SCCM or CHESS, I think. Yes, Drew, of course. I think Roger Bone was the president of SCCM at some point, and they had sort of like this joint conference in 1999, which like defined what is SIRS, what is sepsis. At that point, the understanding was patients with sepsis are like profoundly hypovolemic. What we've come to find is that some patients are hypovolemic, but not everyone's hypovolemic. So giving like a broad strokes recommendation on this patient should get, you know, some amount of fluid bolus because they're hypovolemic is not exactly like wrought with the best vetted data and comes from a lot of dogma. Furthermore, what others have pointed out is that in this guideline, the authors seem to neglect the fact that there was at least 2, I think, RCTs recently, or retrospective reviews maybe. I think they were RCTs. I have to look. I have it somewhere. That, the like bundled care, this 1 hour bundled care, so blood cultures, antibiotics, fluids, lactic measurement, didn't like change any outcomes. The only thing that moved the needle on outcomes is early antibiotics. How early antibiotics, which was another point of contention from others where, this 1, 3 hour, 6 hour thing. So from a CMS perspective, if you identify the patient has sepsis, they want you to give antibiotics within an hour. What we found is that through data, is the patients who benefit most from early antibiotics, say within an hour, are the patients who are the sickest. So if the patient's in shock and you think it's septic shock, either you think it's septic shock or they definitely have septic shock, you should be prioritizing antibiotics within an hour as fast as possible. I agree with that wholeheartedly. Where this starts to sort of fall off a cliff is the sepsis without shock range. In these guidelines, they put in a table where I pointed this table out. This table has been in other places, and I sort of like have an approach to this as well. So, sepsis is definite or possible. If shock is present, it's sort of irrelevant. You give the antibiotics up front as soon as you recognize, because this is the population where it's going to help the most patients, right? The problem is if shock is absent, depending on if the sepsis is definite or probable or possible or even less likely. So this is where we're not sure, so they put it in green, but like this would be more of like a yellow. It's just like green sort of like gives the impression that we should be doing this all the time. This is more of like a yellow recommendation, right? Because you have some time to figure out, does the patient have sepsis? Get more information, get more imaging, get a CT scan, get more history, get more labs, like do something else to figure out if the patient has sepsis. The problem is, from a CMS perspective, when they hit the door, if they screen positive for sepsis from CMS, from this 1 hour bundle, which is not shown to improve anything, just like sort of overuse antibiotics and give fluids, you're supposed to give the patient a fluid bolus, antibiotics, blood cultures, lactic, etc. So it's a little confusing, I think, from a practitioner standpoint, because we're all, and this is, I think, ACEP's problem with it, we're all held to the standard. We're all held to sort of like CMS as this 1 hour bundle situation, because that's like who pays the bills, unfortunately. I'm getting to that. So from a CMS standpoint, who are really piggybacking off the Surviving Sepsis Campaign guidelines, which I think is the issue that a lot of people have with them. Certainly what I can tell from like an ACEP perspective, their issue is that if CMS has taken lead from Surviving Sepsis about antibiotics, fluids, etc., that when we sort of look at the evidence behind each guideline, certainly for fluids, let's keep it at fluids and like sort of timing of antibiotics and fluids. So fluids, this 30 cc's thing has never been like really put up against rigorous evidence. It's like every guideline that comes out from the Surviving Sepsis Campaign, it gets like a weaker and weaker recommendation with more and more wiggle room. And so instead of like maybe being a little bit more direct and saying, we're not really sure how much fluid you should give the patient, that's a clinical call at the bedside, which I think would be sort of the best of both worlds, and I think is what we already do in a lot of ways. Instead of saying that, we're sort of every iteration, we sort of double down on this like observational data that, this sort of mythical 30 cc's is going to sort of like treat sepsis in some way. And I don't know if I personally sort of believe the physiology and the pathophysiology behind that. Nevertheless, do some patients with sepsis need fluid? Yes. Do some patients with sepsis need a lot of fluid? Maybe. If they have cholera, then yeah, you're going to need a ton of fluid. But if you're already in the hospital and you're already, plus 7 liters from your hospital stay and you get sepsis from a pneumonia, does that automatically mean that you need 30 cc's per kg? I don't think so. I don't think so, and I don't think we have the data to support that. But that's what CMS tells us, because they're taking sort of lead from the Surviving Sepsis Campaign, which I think is the crux of ACEP's argument. Then puts us in a particularly precarious situation, because if we're trying to personalize and individualize the care at the bedside, but we're held to these sort of standards or these guidelines that are kind of rigid, and with each iteration they're making them a little bit more nimble, but nevertheless they're sort of rigid in some way, because it comes with financial penalty, right? So if our CMS sepsis bundle is if our CMS, if our sepsis bundle adherence isn't up to snuff, the hospital gets dinged for like monetarily, right? For like reimbursement. So like that's a problem, right? So they want us to figure out, so this is, I think, my problem with it. One is to sort of figure out quickly if the patient has this syndrome that is very heterogeneous, that's hard to define, that there's no gold standard definition, that can present many different ways. Oftentimes the patients are like either they're elderly or they're demented, or they are like so sick that they can't give you a lot of information. So you're just sort of trying to like backfill in and figure this out without a lot of great historical context. There's only so fast you can go. So to put this like, it went from like a 3 and 6 hour bundle to now this like 1 hour bundle. And like the bundle evidence hasn't really supported that we should be using the bundle at all outside of early antibiotics in septic shock. So source control, early antibiotics in septic shock sort of has the most gusto. And that's why I personally practice, now this is just me, if the patient's in shock for whatever reason, if I am not 1 million billion % certain it's not sepsis, I usually give a dose of antibiotics up front, because I'll never get that time back if I don't give the dose of antibiotics now, if they have shock and I don't know if it's sepsis or not. Because I can always stop them tomorrow, right? I can stop them later, I can stop them tomorrow. I can stop them when the blood culture is negative for 48 hours, whatever it is. Outside of that, you have some time. Right? I think from the RCT or the study that I'm referencing, which I'll try to look up really quick, I think where the time aspect really started to impact mortality was like more than 6 hours. So Dr. Gallo, absolutely wonderful physician, incredibly smart, pointing out you can always stop. It's like cooking, right? You can always add, but you can't take away. So, which it's not like, I guess, like doesn't like do a lot of heavy lifting as far as the cooking analogy goes. But as she points out, you never get that time back. So if you're standing in front of the patient, they're in shock, and you're debating at all if they have sepsis or not, give the antibiotics right there as broad as you need to, right? That's one thing that I think we miss out on is like, broad spectrum antibiotics isn't just vancomycin. Broad spectrum antibiotics is what do you think the underlying pathology is, and then what's the most likely bugs in that pathology. Because if the patient has meningitis and you give them vancomycin, you're not really covering meningitis. So yeah, I did talk. That was like one of the first things I said, Alice, was about the prehospital antibiotics. So just as a recap, prehospital antibiotics. Do I think at some point, somewhere down the line, if you have like a sick patient in shock, some way to work in giving a dose of antibiotics, is that going to be a possibility? I don't hope so. I think that would make a ton of sense at some point. I don't know if we have the protocols in place, the screening tools in place, the de-escalation tools in place, the identification tools in place. And they admit that in the guidelines. We should screen sepsis pre-hospitally. We don't know how to do that. We don't know what score to use. And we also don't know how to identify the patients pre-hospitally who have sepsis. We can screen them very well, but the specificity of all these scores is very low. So you're going to have a lot of false positives, which then is going to lead to overtreatment with antibiotics, and then going to lead to more resistance, and I'm sure other things. So, I think the pre-hospital antibiotics, much like pre-hospital blood, might eventually sort of make its way into the forefront. I don't think we're there yet. And I don't think the evidence they cited wasn't overly strong. So that's, sort of like more to come on that. I did point that out to Brandon Bryan from Critical Care Scenarios as something that I would ask personally. Other things with the guideline. So one of the things that I thought was like funny, but not funny in some ways is, where's it at? So, the recommendation for the MDR pathogen coverage, I think it makes sense. And I think we've been doing this. We do this already, which is, if the patient has a history of multi-drug resistant organisms, we certainly cover as broad as that multi-drug resistant organism is. So if the patient has ESBL from cultures prior, we skip over the Zosyn and go to like meropenem or something. Which then gets back into the other question with pre-hospital antibiotics. How is that going to be helpful if you're picking a patient up from the nursing home? Maybe they have a history of multi-drug resistant organisms. How are you going to know that at that point? So even if you were to give them antibiotics, if they have a history of multi-drug resistant organisms, you're not going to cover it broadly enough. So maybe that'll sort of give a false sense of security, like, oh, the patient got pre-hospital antibiotics, whatever, and then we don't look at the culture data that we have at the hospital from before and say that, oh, wow, they had a UTI 2 months ago and it was actually ESBL and they got Zosyn en route, but they're not covered because it's Zosyn and we need meropenem. So I think like that's one of the issues. But with the pre-hospital antibiotics, I think we already sort of cover MDR pathogens if the patient has a history of them. Unfortunately, most of like Epic and our other EMRs sort of talk to each other, so we can access old microbiologic data to see if they have history of MDRs. But when you start to like plug that into like sort of certainly the pre-hospital realm, I think there's not a way to sort of like guard against if the patient has an MDR and you give them antibiotics pre-hospitally if you're covering appropriately. So, they want you to cover MDRs if the patient has a history of MDRs, which I certainly agree with. They want you to not use empiric MDR if the patient doesn't have a history of MDR, which I also agree with. So, practice patterns are such that some providers will just sort of go super duper broad with like meropenem, even if the patient doesn't have a history of MDRs, which do I do sometimes? I do that sometimes. But the times that I do that is when the patient is in shock, and dying from their shock. So the pressors are going up, maybe their pressors are going up. There are signs of sepsis, whatever they are, whatever I deem those to be at that point in time, are not better. If the patient seems to me they're getting sicker, and I know that's like nebulous term and I can't really define that either, but that gets back to that clinical diagnosis thing. If the patient's getting sicker in front of me, I will escalate and give meropenem, because getting back to Alice's point, we never get that time back. And if the patient has an MDR bug, because it's not impossible to have an MDR bug and not be exposed to antibiotics, whether that's like in the environment or in like wherever the patient picked up that pathogen. It's not impossible to have an MDR, right? There's like community-acquired C. diff, right? That's like a thing. And not that I'm saying the patient has C. diff, but that would be a consideration. But if the patient's getting sicker in front of you, even though Surviving Sepsis says not to cover MDR without any, they say low risk of a specific MDR pathogen, if they're like sick AF and they're in septic shock, there's sort of no downside to like giving one dose of meropenem until you get more information. But that's, I do that on a case-by-case basis. I don't do that for everyone. I don't start at meropenem, certainly. But some people do. They would recommend against that. I would agree with that, certainly. But if the patient's getting sicker in front of you, I would go to use meropenem. Let's see here. So what else? No anaerobic infection. See here. Other things that caught my eye on here. So there was like sort of the decontamination of the digestive tract, which they're actually recommending to do, which is based on or it wasn't based on the SUD ICU trial, but giving, decontaminating the gut of aerobic bacteria, but leaving the anaerobic bacteria, which apparently has a short-term mortality reduction, which I thought was interesting, which I don't do, and I don't know if anyone does that specifically, which I don't do, and I would feel would be wrought with like complications like C. diff or other antibiotic microbial resistance, which apparently it's like it doesn't lead to microbial resistance, and there was like some back and forth that I saw on another site about that, which I thought was interesting. So, a new recommendation is doing decontamination of the digestive tract, which I thought was interesting, which I don't do. I don't know if a lot of ICUs do that. On rounding it out, the last thing that I thought was interesting was, the liberal versus conservative approach to resuscitation. So the liberal versus conservative fluid resuscitation approach. So the strategy, which essentially they just are like leaving it to us, which is, either a liberal or restrictive fluid resuscitation strategy based on the patient factors, which again, I think is like a softening of the stance of like everyone needs 30 cc's per kg or like how much fluid to give. This is, I think, controversial in a lot of ways because it's leading away from this like regimented, like we have to give this much fluid. But again, when these guidelines like inform a lot of CMS's like rules and regulations, that's where it gets confusing to us as clinicians on like, if we want to individualize care and Surviving Sepsis is saying to do X, Y, or Z, but they're saying that, we have to sort of like individualize it more, but then CMS sort of puts out all these broad strokes and says we need to do 30 cc's, we need to get a lactic, we need to trend that to resolution, we need to give broad spectrum antibiotics as soon as we think it's sepsis, not even septic shock. And these antibiotics have to be give it in 1 hour or whatever. It's sort of like a tug of war. It's like we want to have like individualized patient-centered care, But the system at large, like CMS, is sort of controlling reimbursement, at least in America. And then that leads to, us not being able to individualize the care, which I think is a lot of the ACEPs is like their argument against these guidelines. So, I don't know, I'm probably going to have to wrap this up, but send me your questions about the guidelines for Brandon and Brian for the lead author tomorrow. This is a great way to have something that you want specifically addressed directly to the author, and they might address it tomorrow and sort of give more sort of more insight into what they were thinking and why they had a certain recommendation graded what it was, and what their thoughts were, and how it could be applicable or not to our practice, which ultimately is what everyone has to do with guidelines. They're saying, what everyone sort of says is guidelines are just guidelines. They're not meant to be sort of end all be all. They're just meant to guide us, which I agree with. You have to it would be interesting, and it would be good to know where the author's thought process was coming from. So, appreciate everyone's time, and see you later.